only going to focus on non-pulsatile tinnitus, subjective tinnitus, so there's no way to objectively verify if the patient has tinnitus or not. As already told, we all know that about 10 to 15% of the people perceive tinnitus continuously, and then in an elderly population it goes up to 32%, probably to age-related hearing loss or presbycusis. 25% of the people, of the affected people, report that their tinnitus really interferes with their lives and that it causes considerable amount of distress, and there are a lot of problems going from depression to social withdrawal, anxiety, insomnia, and so on. But if you look at the treatments, we have treatments for tinnitus. Only a few respond to those treatments. Some respond to counseling, some respond to hearing aids, some respond to ear implants, some to masking, some to active amplification, medication, and so on. But on average, it seems that it doesn't have an effect. It's only a few or a couple of people that respond to a specific treatment. And there are a lot of people that do not respond to any treatment at all. The problem so far is that for most of the treatments that we suggest are what we call causes symptomatic relief. It's not a causal treatment. But indicating that some people respond to certain types of treatment suggests that there are different subtypes of tinnitus. And more people believe in that. There's no cost program sponsored by the European Union that basically helps collaborating on a lot of researchers to collect data in the same way so that we can look for subtypes, because we need a lot of data to look for subtypes. A general accepted idea is that there's a lot of auditory input, and basically it sets up a cascade of neurophysiological changes in the central auditory system that causes a phantom sound. So although it starts peripheral, it's indicating that it is a brain problem. And we know that if you cut or resect the auditory nerve, 60% reports that they still have tinnitus, although you do resection of the cochlear nerve. The interesting thing is, why does the brain create tinnitus? Well, actually, we can induce tinnitus in most of the healthy subjects. Healthy subjects that have no hearing loss, if we put them in an anechoic chamber for 5 minutes, 94% reports that they perceive a phantom sound. And a similar study was done at UCLA, where they asked 18 subjects to wear an earplug in one ear for 7 days. And after 7 days, 14 out of 18 healthy subjects report that they were perceiving a phantom sound. So it seems that the brain is involved and that the brain is creating tinnitus. And we know that there are a lot of brain areas involved in tinnitus. On the left side, you see all brain areas involved in tinnitus during resting state, meaning that the patients are relaxed, are not doing a specific task, and we compare them to health controls that have no tinnitus. And you see a lot of brain areas that spontaneously are active. Some we can relate to the loudness. Some brain areas we can relate to the annoyance or to the distress component, but there are a lot of areas. And it's not only based on source localized EEG or MEG, but also this is a meta-analysis that we've done on PET data, and you see a lot of brain areas involved. But the question is, why is the brain creating tinnitus? Well, more and more neuroscientists believe that the brain is not just a passive thing, receiving information and responding to that information by a motor response. No, it's an active brain. We call it the Bayesian brain because it's done in a specific way. Basically, the idea is that you're constantly going to predict what's going to happen, and that's a top-down mechanism. And you compare it to what you perceive, and that's a bottom-up mechanism. When there is no difference between the prediction and the external stimulus or stimuli, there's no prediction error. You don't have to do any updating, and you do not have to reduce the uncertainty. But what happens if there's a difference between what you're going to predict, what's going to happen, and what externally happens? Then there's a prediction error. And the brain tries to compensate for that, tries to update that, and for future events, it can better predict what's going to happen. And basically, it reduces the uncertainty. It's a very efficient way of the brain. But what happens if some of the input does not arrive when there is a sensory deprivation? Well, this leads to a limit of information that the brain can acquire. So there's a difference between what the brain is going to predict, because it tells, well, we have to hear certain frequencies, we have to hear certain tones, and what you're actually hearing. So there's an increased uncertainty between what is predicted top down and what you perceive bottom up. And to reduce that uncertainty, well, the brain will look for information. It will look for more information in the environment, or it will try to fill in the missing information, basically to reduce the error. That's just basically the model. My colleague already told you that the brain is basically a network, connected, different brain areas are connected with each other. When we look at a tinnitus brain in comparison to healthy controls, what we see is that we have major hubs, similar to how computers are connected. If you look at the Google website, you have a lot of links with other websites. If you look at my personal website, there are only a couple of links. So the Google website is really well linked. Well, in a tinnitus brain, we see the same thing. The auditory cortex is connected with a lot of other areas in comparison to healthy controls. And this is just during resting state. You also see more anterior areas that are also all forming a hub. We know that the auditory cortex is important in bottom-up information, sending information to the brain, and that the pregenual ACC extending to the ventral medial prefrontal cortex is more related to top-down, predicting information. If we now focus on the hubs, well, in the auditory cortex, we think that there are actually different mechanisms going on. When there's only little differentiation or a small amount of hearing loss, we think spontaneous hyperactivity can compensate and can create tinnitus. When there's more differentiation, where there's a larger range of hearing loss or more hearing loss, we think map-plasticity becomes involved. When there's a huge amount of hearing loss at different frequencies, we think probably memory becomes involved. And all these mechanisms have the same idea, try to fill in the missing information, the information that you're not able to perceive anymore because you have hearing loss. So, if we look at hyperactivity, well, we know, based on fMRI, that there's increased activity in the auditory cortex when you present tinnitus tone in comparison to a non-related tinnitus tone. If you do source localized EEG on resting state people, so people are relaxed, doing nothing, what you see is that in tinnitus patients, in comparison to controls, you see increased activity, gamma activity, in the auditory cortex. That correlates with loudness. So the louder you hear your tinnitus, the more current density you see in the auditory cortex. Well, if you have hyperactivity, and if that's the mechanism, then you can probably modulate that activity. And we have some tools to do that. One method is transcranial magnetic stimulation. So basically, you send magnetic pulses that can inhibit ongoing spontaneous activity. And we see that it has some effect. But one of the problems is that in most patients, the tinnitus comes back. If you do it only for 20 minutes, up to 30 minutes, the reduction is only 1 to 2 minutes, and then the tinnitus comes back. There's some people in Regensburg that do multiple sessions, 10 sessions, and it helps in some people. Some people, they have benefits even after 2 years, but in most people, the tinnitus comes back. So the next option would be to implant the patient with a cortical electrode. And we implanted 43 patients with a cortical implant. It's a very invasive thing, and of course we try every other possible treatment before we go to implant these patients. And what we see is that in about 60% of the patients, we are able to suppress the tinnitus. There were only a couple where we really eliminated the tinnitus. But the interesting fact was that in some patients, we had no response at all. So although we know that they responded on TMS, when we implanted the patient with a cortical implant targeting the auditory cortex, it didn't do anything at all. One of the reasons could be because there's probably another mechanism involved, and that's map plasticity. We all know that the primary auditory cortex is tonotopically organized, going from very low frequencies up to very high frequencies. And in tinnitus, there seems to be a tonotopically reorganization. Basically, if you give an animal a noise burst, what happens is that certain frequencies become more presented and that other frequencies are less present anymore. And a colleague of mine, Dr. Kilgard, tried to develop a method to basically reorganize the tonotopical map so that you have more or less the same tonotopical map as before the noise explosion, where you have differentiation. And the idea is that you stimulate the vagal nerve, and the vagal nerve goes up to the nucleus basalis, the solitary tract, and there you have pathways that basically showers or release the cholinergic system and the noradrenergic system. And both systems are involved, are important in plasticity. And the idea is that you basically try to trigger those neuromodulators and also target them specifically to the auditory cortex. And you can do that by pairing with tone therapy, so sound therapy. And basically you present all the tones except the tinnitus tone. We tried it in humans. It was just a pilot study, just to see if this was doable or not. We implanted 10 patients with a vagal nerve electrode. And after 4 weeks, and that's one of the weaknesses of the method, that it's very intensive. So for 4 weeks, the patient has to come in every day to the clinic and have a treatment for 2.5 hours every day. So basically, the idea was stimulate the vagal nerve and at the same time present tones, all the tones except the tinnitus tone. And we have some effect. If you look at the tinnitus handicap inventory, you see a reduction immediately after treatment and also after 6 months follow-up. Also for the minimum muscle level, you see a reduction, which is a good thing. But only a couple of patients responded. Another possible mechanism, and again it depends on the differentiation, the amount of hearing loss or the problem down the auditory pathway, could be memory. If you look into the literature, you see that a lot of papers also report the involvement of memory-related areas. The hippocampus, the parahippocampus seems to be important. On our meta-analysis, we saw the parahippocampal brain area important, the hippocampus was important in the fossil plate morphometry study. Also, resting state fMRI indicated the parahippocampal brain area, and also fcMRI also suggested the parahippocampal/hippocampal brain area to be involved. And we did some tests. Is it really true that depending on the differentiation, in this case hearing loss, memory becomes involved? Well, when we compare a patient that only has a mild hearing loss to health controls, we saw increased gamma activity, just hyperactivity, as we already saw in point number 1. When we compared health controls with patients that have severe hearing loss, the auditory cortex seems not to be important anymore, but the parahippocampal/extending to the hippocampus becomes more important. And when you directly compare tinnitus patient with a mild hearing loss with tinnitus patient with a severe hearing loss, what we see is that severe hearing loss patients actually see the opposite. You see a decrease in activity of hyperactivity in the auditory cortex. We also found out that depending on the hearing loss, you see more communication going from the parahippocampal brain area up to the auditory cortex. We tried to further confirm our ideas, and we correlated the hearing loss, the mean hearing loss, overall frequencies, with brain activity. And again, there was confirmation that the more hearing loss you have, the more the hippocampus becomes important, and also the range of hearing loss. So at how many frequencies you have hearing loss, you see that it correlates with the parahippocampal brain area. And actually, we have some evidence that the hippocampus / parahippocampal brain area is important. Some time ago, there was a test done where they injected amytal, so basically sedate, in the anterior choroidal artery. And it basically supplies blood to the hippocampus, amygdala, parahippocampus. And when you do that, for about 10 minutes, you see a reduction again in the loudness of the tinnitus. They perceive the tinnitus is less present, but it's only for 10 minutes. It's a very dangerous procedure to do, so it cannot be used as a standard treatment so far. And you can see that in about 3 patients, it was only done on 6 patients, in about 3 patients, we had a reduction contralateral to where we injected the amytal of 60 to 70%. So that's a very good successful suppression. We also implanted a patient, and we had a very good result, but only for 3 weeks. So the patient was implanted with an electrode targeting the parahippocampal brain area, and we could suppress the tinnitus, but only for 3 weeks, and after 3 weeks it came back. One of our ideas is that basically the subject was adapting to stimulation. We tried different stimulation parameters, but always it was coming back to tinnitus. However, this is only the bottom-up approach. There might be also a top-down approach. We know that the trigeminal ACC is an important hub also in the tinnitus network. Well, if you go back to the pain literature, and Dr. Muller already suggested some similarities between pain and tinnitus in his talk on Wednesday, well, we know that there are different pathways, ascending pathways, sending information to the brain, but there's also a descending pathway, a top-down pathway, that basically sends information to your interneurons and that can block information or avoid information to descend to your brain. We know that when you have a placebo effect, you see increased activity in the trigeminal anterior cingulate cortex, which is part of your descending pathway. The question is, can we apply this also to tinnitus? Well, there was a model introduced by Rhinology a couple of years ago, and he suggests that basically in tinnitus patients, there's a problem called the noise cancellation system. And there's an issue with that noise cancellation system. This is basically the noise cancellation system, and for most of us, it works. The AC is running now, but we do not notice it anymore because there's no important information in that. But Rhinology claims that in tinnitus patients, something is wrong in that noise cancellation system, which entails the ventral medial prefrontal cortex extending into the trigeminal anterior cingulate cortex. We just recently published a paper that suggests that the percentage of time that you're aware of your tinnitus correlates with the exact same area, the trigeminal anterior cingulate cortex. So the question is, can we modulate that area and confirm that it's also an important part in the tinnitus network? Well, we published a study also doing TMS using a different type of coil, a double coin coil, which can go deeper into the brain, modifying the anterior cingulate cortex, going from the dorsal up to the trigeminal part of that of the anterior cingulate cortex. And after multiple sessions, we were able to suppress the tinnitus. Quite good, actually. Here you see some of the results. This was done at 40 patients, placebo control, and everything. And actually, we were able to suppress the tinnitus. But again, the same problem occurs. In some patients, you have very good response, and they're helped for a couple of years. Sometimes they have to come back just to have a maintenance treatment, but they're helped. With another patient, it comes back after a week. Sometimes it comes back after a day or 2. So we implanted also a patient, or 2 patients, targeting the same area. The dorsal anterior cingulate cortex extending to the trigeminal rostral anterior cingulate cortex. And this was quite a success story. We only implanted these 2 patients, and 1 patient is very good. We do a follow-up of 3 years now, and he's still very good. He's able to work again, and he went basically based on, this is wrong, based on this tinnitus questionnaire, going from grade 4, which is basically, I cannot cope with my tinnitus, I'm almost suicidal, to grade 1. I have tinnitus, but I don't care anymore. Also, we have suppression in the tinnitus confirming the noise cancellation system. What is now the main message? It's not to implant every patient that is walking around, of course not. But I think there's a confirmation that there are different subtypes of tinnitus. And depending on the subtype, we have to look for different types of treatments. I think we have to have a better understanding what the exact mechanisms are, but keep in mind that there are probably more than one mechanism that can explain tinnitus. Thank you.
Well, I think it's definitely going to be promising because now we can do source localized EEG, so we're looking at specific areas. We didn't do the ACC, although we think it's possible to do it. So far, we only did the more posterior areas, and it seems that it's doing something for tinnitus. The interesting thing was that it was not changing the activity itself, but the connections were changed, and that we also had suppression only for the annoyance component, but not for the loudness component. So definitely, that could be a suggestion. And the good thing is that it's self-regulating, in the sense that the patient is really training his own brain, and it's less invasive.
This is a good point. This is another indication that the sound of the tinnitus is one thing, and another thing is the suffering part, is the annoyance part, and they are not correlated. You can have people who have a strong tinnitus and say, well, if I just know I don't have a brain tumor, I'm fine. Or you can have people who have such weak tinnitus that you can hardly measure it on an analog scale. And they say, if you don't fix my tinnitus, I'm going to kill myself because I cannot live with that. And that is definitely two different things. Another thing, you are kind of surprised also that there are two different systems. And why did nature do such stupid thing as give us tinnitus and neuropathic pain? And neuropathic pain does not serve any purpose. Well, you have other things also. You have in the immune system, you have autoimmune reactions. The immune system is supposed to do many things, but one thing is to kill intruders, bacteria, virus, and so on. But sometimes it kills self, your own cells. And this is probably also, you would think that nature was ideal. After all these billions of years of development, you would think that at least they must have figured out everything that was good for us. But probably not, because you can find negative things in many systems. I mentioned that